Okay, so welcome everyone. Good afternoon and welcome to today's presentation, Language Access Rights and Benefits Access for HIV Positive New Yorkers. My name is Michelle Peterson and I'm the Senior Training Manager for the Empire Justice Center. I do need to acknowledge that today's training is made possible by the Legal Action Center and the New York State Department of Health AIDS Institute HIV Education and Training Program. So before we get started, just a couple of housekeeping notes. If you have any questions on the material that's being presented today, we ask that you put your questions in the chat box, and the chat box is going to be monitored by Alexia Mickles. A copy of the PowerPoint materials were emailed to you earlier today. And at the end of the meeting, or at the end of the presentation today, there's going to be a brief survey evaluation. So if you could take a few minutes and give us your feedback, that would be very much appreciated. So we've got a lot to cover today, and I'm going to go ahead and turn it over to our presenters, Cheryl Keshner and Fiona Wolfe, and they'll introduce themselves.
Good morning, everybody. My name is Cheryl Keshner. I'm a senior paralegal and community advocate in the Long Island office of the Empire Justice Center. I work on issues related to immigration, public benefits, housing, and language access, and a variety of other issues. And I coordinate the Long Island Language Advocates Coalition.
Hi, everybody. My name is Fiona Wolfe. I am the senior managing attorney in our health law team. I'm based up in Rochester, New York. We primarily work on post-enrollment health insurance related issues for our clients, mostly Medicaid, Medicare, but also some commercial insurance issues as well. And Michelle mentioned earlier that my colleague Alexia Mickles is on too, so I'll let Alexia say hi.
Hi, everyone. Alexia Mickles, she, her, and I'm a staff attorney in the health law unit, also in Rochester. I will be monitoring the chat, and since we're a relatively small group, I really want to encourage folks to be as chatty as possible. Feel free to ask questions. We are here to help, and we'd love to answer as many questions as possible. Thanks.
Okay, so let's get started. Title of today's presentation is Language Access Rights and Benefits Access for HIV Positive New Yorkers. And our objectives for today are to better understand the language access obligations of healthcare and other benefits providers serving individuals who are HIV positive or at risk of acquiring HIV, exploring the public charge concerns and protections for immigrants who need government assistance, and informing members of the HIV plus community about available health programs and services. Okay. So some of the topics we're going to cover include HIV and racial disparities, impact on immigrants, defining common language access terms, federal and state protections, the Safe RX program, public charged, uninsured care programs, Medicaid, federal public health emergency, language access in hospitals, appeals, the Fair Hearing Demonstration Project, and as well as additional resources. Next slide. So we do want to acknowledge those we have lost, and I just wanted to share with you a statement by U.S. Health Secretary Javier Becerra that was made on the 40th anniversary of the AIDS epidemic. Despite the progress we've made over 4 decades, HIV persists as a serious public health challenge globally. Fortunately, ending the HIV epidemic is now within our reach. As we mark the 40th anniversary of the first official report about AIDS on June 5th, 1981, we pause to honor the more than 32 million people who have died from AIDS-related illnesses globally, including 700,000 people in the US. Reflecting on those we have lost to HIV and AIDS and standing alongside the HIV community, we recommit ourselves to ending the HIV epidemic, continuing the work that must be done, re-engaging people with lived experience and a wide variety of stakeholders from all sectors of society, and to re-energizing our efforts to accelerate progress and ensure equity. Next slide. So let's look at HIV today. 40 years have passed, but where are we now? There are still 38 million people who are HIV positive worldwide. 1.2 million people in the US who are HIV positive, and approximately 13% of people who are HIV positive in the US are unaware that they are infected. At present, there are over 30,000 new HIV infections diagnosed yearly in the United States. Next slide. Clearly, there are a number of racial disparities related to HIV as a result of racism, economic disparities, educational disparities, homophobia, and a number of other issues. In 2020, Black people and African Americans represented 12% of the US population, but accounted for 42% of new HIV diagnoses, which is 8 times more than the infection of the white population. In 2020, Hispanics, Latinx represented 19% of the US population, but accounted for 27% of new HIV diagnoses, which is 4 times more infection than the white population. And as of December 2021, 103,900 New Yorkers were living with diagnosed HIV. 22% of these lived outside of New York City, and the total racially in the breakdown in New York State is 45% Black, 28.8% Latino, 22.8% white, 2.5% Asian, as well as smaller percentage for Native American and Asian and Pacific Islander. Thank you. Next slide. So this is a chart from the CDC, just sharing new HIV diagnoses among the most affected populations in the US and dependent areas in 2019. As you can see, Black, African American, male-to-male sexual contact is the highest. Hispanic, Latino, male-to-male sexual contact is the next highest. White, male-to-male sexual contact is the next highest, and so on. So just wanted to show this for reference so we can get a sense of the continuing racial disparities and the work that needs to be done. Okay, so even though many people are diagnosed, not all are able to access or retain the medical care. According to the CDC, while 87% of people with HIV are diagnosed, only 56.5% retain medical care. Key supports needed to retain medical care include access to medical insurance, food, housing, economic supports, emotional support, substance abuse treatment, education and transportation. And providers need to make many improvements, including, but not limited to, cultural awareness and representation and linguistic accessibility. So when we talk about accessibility and healthcare, we also need to address health literacy. According to the U.S. Department of Health and Human Services, 90% of adults in the United States experience difficulty understanding health information that currently is available through the media, healthcare facilities, and communities. And this occurs when information is not provided in the patient's preferred language, or if the way information presented is not well suited for the patient. So oftentimes we talk about plain language, making sure that the message is conveyed in a way that people can understand it and in a manner to which they can relate. Health literacy is not solely based on an individual's ability to read. It is their ability to read, listen, and analyze health information, and then apply that information in order to make complex healthcare decisions. Next slide, please. So let's talk about the need for language access. About 22% of US residents over the age of 5 speak a language other than English at home. And of those persons, according to the US Census, approximately 37.6%, or 35 million people, are considered limited English proficient, or LEP, meaning they have a limited ability to speak, read, write, or understand English. And the term LEP is what is commonly used by the Department of Justice. So we do still use that in our presentation, but we do want to acknowledge that many people, that there are other preferred terms, particularly in the educational context. English language learners, multi-language learners are also other terms which are commonly used. According to the 2020 census, there are 2.5 million LEP New Yorkers, comprising 14% of the state's population. And let's not forget that people who are deaf or hard of hearing or blind or low vision or who have sensory challenges also need language assistance. So in addition to the LEP, limited English proficient term I just shared, let's talk about language access. Language access constitutes the right of limited English proficient individuals to receive meaningful access to recipient programs, benefits, and services, particularly those receiving federal funding. This may include healthcare providers, schools, law enforcement, courts, social services, community agencies, and other settings. So for community agencies, if you are receiving even a penny of federal funding, you are legally obligated to provide language access, not to mention that it's the right thing to do. Language assistance services include interpreter services, which are oral. People often confuse interpretation and translation services, which are written. And these are provided for the individuals who need language assistance or who need communication assistance services. And I mentioned meaningful access. Meaningful access is language access that results in accurate, timely, and effective communication at no cost to the individual who is limited English proficient. So sometimes we see that people who go to the local social service office may be kept waiting longer if they are not proficient in English than someone who is proficient in English. I recently had a client who waited 5 hours to get an interpreter. This is not supposed to happen, and it is illegal and a violation of federal law. So please keep your eyes open for those types of situations. Next slide, please. Federal protections. So Title VI of the Civil Rights Act of 1964 states that no person in the United States shall, on the ground of race, color, or national origin, be excluded from participation in, be denied benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. As I stated earlier, this may apply to many settings: law enforcement, schools, courts, health agencies, community agencies, and others. And national origin discrimination includes discrimination against an individual based on the language they speak or their ancestry. So national origin discrimination includes language access, and failure to provide that is a violation of Title VI. Next slide, please. Executive Order 13166 was issued in 2000 by President Clinton, and it prohibits federal agencies and recipients of federal assistance from discriminating based on national origin by, among other things, failing to provide meaningful access to LEP individuals. So it further elucidates what the obligations are of those agencies. Okay, please. Obligations and enforcement. To determine if a recipient of federal funding is providing meaningful access, the Department of Justice has issued an LEP guidance, and they use a 4-factor analysis. One is based on the number or proportion of LEP individuals to the population at large, their frequency of contact with the program, the nature and importance of the program, and the resources available. Now, language advocates have been questioning some of these requirements because sometimes frequency of contact with the program may not necessarily indicate what the need is. And so I think there are efforts underway to possibly re-examine this 4-factor analysis and broaden it a bit. But those are advocacy efforts that are underway by national language advocates, but just wanted to give you this sort of framework. Every county and state agency must have a Title VI civil rights complaint procedure. So if the agency is not complying with their language access obligations, members of the public do have a right to file a complaint. And there are various methods, and we're going to talk about that further. Next slide, please. So let's talk about some best practices, and this can be within your own agency as well. It's always a good idea to use I speak cards at multiple points of contact. Many times we see law enforcement using those, where the card itself will state in a variety of languages that I need an interpreter, and the person can point to the language of their choice. Likewise, language identification posters need to be posted at various points of contact, advising the individual of their right to an interpreter at no cost. And even if the individual does not request an interpreter, but you think comprehension is limited, or the agency or healthcare provider where your client is attending believes that comprehension is limited, they should be offering language assistance. They may utilize competent bilingual staff or professional interpreters. And let's talk about competence. Being bilingual does not necessarily mean that one can be an interpreter. It is a very skilled ability. And so sometimes there's an assumption that because somebody's bilingual, they can interpret or they can translate a document. That is not always the case. We'll talk a little bit more about best practices for interpreters later. By phone lines should be language accessible, and your staff should be fully trained on how to assist people who call who do not speak English. It is a good idea to use bilingual staff or professional telephonic interpreters. Children absolutely should not be used as interpreters. Reasons for that, there could be a conflict of interest. Children often do not have the necessary language skills to act as interpreters. And, it puts them in an uncomfortable and often inappropriate situation when they have to translate for their parents, where they're privy to certain information that they should not know about. There may be also a conflict of interest using other family or friends. So when engaging with an interpreter, make sure to speak directly to your client, not say, ask her this or ask him that. Continue speaking to your client as though you're having a conversation. The interpreter is the intermediary conveying the message. And also it's a good practice to indicate that individual's language needs in your records. So I often deal with the Department of Social Services, and people have to go for employment assessments, sometimes substance abuse assessments. They deal with multiple workers within the agency. If the various contract agencies or the various departments within social services are not aware of this person's language needs, then each time they go, they're going to have to continue to seek that help, and they may be denied the services that they need. Next slide. Okay, we spoke a bit about interpreters. So as I said, being an interpreter and being competent means more than identifying yourself as being bilingual. You need to have a knowledge of both languages and also of the necessary words and phrases, in this case, for the HIV/AIDS program or service. Cultural awareness, competence, and humility is also of utmost importance. And I'd like to recommend that you look at the class standards, which recommend certification, particularly in the healthcare setting. Those are national standards, which are particularly recommended for hospitals and healthcare providers. In terms of who should act as an interpreter, having trained, competent, bilingual staff is probably the preferred method, having that face-to-face contact. An in-house full-time staff interpreter is also a good idea. Contracted professional interpreters, such as Language Line, or there's an organization called Found in Translation in Massachusetts, which trains community members who speak languages of lesser diffusion to act as interpreters, and then telephonic interpreter services as well. Okay, so how does language access affect access to healthcare? Language discordant encounters result obviously in worse health outcomes, reduced access to health information, decreased patient satisfaction with care, a lower return rate for follow-up care. We were talking about that before, about the difficulty in getting folks to follow through on their treatment and care, and ultimately untimely access to health services, including preventive services and screening. and as well as problems with confidentiality and misinterpretation, obviously. Next slide. Okay. So communication with service providers is vital in order to access medical services, financial assistance, and support. Because of the stigma associated with HIV, LEP individuals may be reluctant to bring a friend or family member to help communicate with service providers. So they may struggle on their own if they're not provided with the language assistance that they need. Lack of effective communication affects patient safety, resulting in inappropriate use of prescribed medications or inability to comply with follow-up instructions. And lack of effective communication may also result in inappropriate disability determinations and denials or discontinuance of benefits. Next slide. Okay, so we're going to talk a bit about the U.S. Department of Health. U.S. Department of Health, under Section 1557 of the Patient Protection and Affordable Care Act, prohibits discrimination on the basis of race, color, national origin, age, disability, or sex, including pregnancy, sexual orientation, gender identity, and sex characteristics in covered health programs or activities. And they have an Office of Civil Rights, which enforces these provisions, and you'll see the link at the bottom of your screen. This provision of the ACA was under attack by the prior administration. And so the protections are still there, you know, but there was quite a bit of struggle around this provision of the ACA, and the Trump administration was trying to get rid of the protections for all these populations, particularly folks who are transgender, to be covered in health-related services. Next slide. Okay, in New York State, so in 2011, Governor Cuomo signed Executive Order 26. Basically, that required that vital documents be translated into the 6 most frequent languages, and that interpretation be provided in any language needed. This was particularly for state agencies, so offices like the New York State Department of Health, Department of Labor, New York State Office of Temporary and Disability Assistance, and there's a whole laundry list which you can find on their website. In 2022, that became a law. It was codified by Governor Hochul, which was a great win for language advocates. We had worked for that for years. And also there was a newly created Office of Language Access. So if individuals have problems with state agencies, they can file complaints through the New York State Office of Language Access. In 2022, the requirement to translate vital documents was expanded. So now state agencies must translate vital documents into the 12 most frequently used non-English languages. And that needs to be updated periodically based on census data. So that includes Spanish, Chinese, Russian, Yiddish, Bengali, Korean, Haitian Creole, Italian, Arabic, Polish, French, and Urdu. There is also the flexibility for additional languages to be added by each agency based on regional language needs and other factors. So, for example, in upstate New York or Western New York, there's a large Somali population. In other parts of the state, there's a large now Ukrainian or Afghan population. So there may be regional variations that some of those agencies will adopt in order to meet the needs of those community members. The New York State Language Access Law requires, as I said, that interpretation services be provided between the agency and the individual who's seeking services in their primary language. The agencies must publish a language access plan and designate a language access coordinator who will monitor implementation of the plan and ensure that all staff are fully trained. Next slide. So what are vital documents? Vital documents can consist of consent forms, complaint forms, intake forms, written notices of rights, changes in benefits or denials, applications to participate in a program or service, and information regarding that program or service. This is not necessarily the New York State law, but documents, according to federal law, all documents which need to be translated are for each limited English proficient group, which comprise 10% or 3,000 people within the eligible population. And vital documents are for each LEP group, which comprises 5% or 1,000 people within the eligible population. The state agencies now have the option to add, as I said, up to 4 regional language variations. Next slide. Okay, so this is OTDA 0680M5, providing access to temporary assistance for persons with disabilities or limited English proficiency. This is a directive from New York State Office of Temporary and Disability Assistance to the local social service agencies regarding non-discrimination in administration of programs. The goal is to ensure meaningful access to cash assistance, SNAP, and other programs such as HEAP, Medicaid. People with disabilities and or limited English proficiency are covered under this directive and should not face additional delays or barriers in the application process. So that example that I gave before about the person waiting 5 hours at the local social service agency, that was a violation of the state directive as well as of federal civil rights law. The directive also indicates that the agencies must provide competent agency interpreters, provide a reasonable accommodation for people with disabilities, and document the need for language services in the agency record. And also there is a guidance from the Office of Children and Family Services, which may also provide additional protections to social service recipients. Next slide, please. Okay, another innovation from New York State, which came about also as a result of advocacy in 2012, was that there was legislation enacted which built upon New York City legislation and required chain and mail order pharmacies to provide comprehensive translation and interpretation service. So what this means is that identifying LEP patients on prescriptions so that pharmacists offer those patients the extra help that they need. And there needs to be clearer prescription labeling so that English language learners and those with limited health literacy understand instructions, warnings, and other written materials. So when you go into your local chain pharmacy, you may see signage there in several languages indicating that the person has a right to get information from the pharmacist in their language regarding their prescription needs, as well as any warnings related to those prescriptions. Next slide. Okay, so we talked a bit about language access, and we're going to get back to that a bit, but I want to talk about public charge because we know that language access is not the only barrier for many immigrants who need to access health services as well as other services. Particularly during the prior administration, there was a lot of misinformation circulated regarding public charge. And we have seen within our communities that many people, many people have been afraid to access services, have withdrawn their applications for WIC, for SNAP, and have not enrolled in health insurance or even gotten COVID testing or treatment because of those fears. So what is public charge? Public charge is a determination made by immigration, which could be Homeland Security or USCIS, when a person has applied for legal permanent residency, or when they apply to enter the US via family-based petition, or when they seek to re-enter the country after 6 months abroad if they're legal permanent residents. These are the only 3 scenarios where there may be a public charge determination. The immigration will determine whether that person has depended or is considered to be likely to depend upon certain government benefits for a prolonged period of time for the majority of their support. Rarely does a public charge determination result in deportation. However, as I said, under the prior administration, there was a lot of misinformation that circulated, and many people still are afraid to access the benefits and services that they need. And you can find more information about public charge under Section 212A4 of the Immigration and Naturalization Act. Next slide. So what benefits may be considered in making a public charge determination? The only benefits that may be considered are cash assistance, such as safety net, temporary assistance to needy families, and SSI. Okay. Long-term institutionalization, such as in a nursing home or a rehabilitation facility, which is being paid for by Medicaid, may also be considered. And so this is pursuant to the 1999 INS field guidance on inadmissibility and deportability. Under the prior administration, briefly, the public charge rules had been changed to include Section 8 assistance, which is a housing subsidy, and as well as other benefits such as SNAP. So there were there was a lot of fear related to using any of these benefits, but prior use is not counted, and any changes that were made under the prior administration have been removed. Benefits used by qualifying children and other family members will not count against the person seeking legal permanent residency. So that's really important to know. Many people will not apply for benefits for their children because they fear that it's going to hurt their immigration status. That is not the case. Okay, and as I stated, lingering fear and misinformation prevents many immigrants from accessing necessary nutrition, financial, and health services for themselves and their citizen children. Next slide. Okay, so who is exempt from public charge? This is super important. U.S. citizens and legal permanent residents, refugees and asylees, U visas, which are issued to victims of crime, T visas for victims of human trafficking, VAWA, which is under the Violence Against Women Act, SIJ, which is Special Immigrant Juvenile Status. That's often filed in the case where a child it can be demonstrated that one parent has abandoned the child. Temporary protected status, DACA, unless seeking residency under a family petition, members of the armed forces, their spouses, and their children. And the exemption does not only apply to people who have the status, but to those who have applications pending. So that covers a huge number of immigrants. And honestly, there are very few who could be considered a public charge once you take into account all of these categories, as well as the benefits that we mentioned. Okay, so for more information and resources, I would encourage you to visit the PIF Coalition, Protecting Immigrant Families. They have a tremendous amount of information, as well as resources in a variety of languages, which you can share with your community members. Next slide. So just one last point. Immigrants may access these benefits without fear. Nutrition assistance, such as WIC and SNAP, the Children's Health Insurance Program, Medicaid and Medicare, child care subsidies, heating energy assistance, HEAP, disaster assistance, such as that issued through FEMA, unemployment insurance and workers' comp, Section 8 and other housing programs, Social Security retirement, disability, survivors benefits, school meals programs, educational financial assistance, as well as other programs. Okay, so please get the word out to your community members that let's dispel a lot of the misinformation related to public charge. Now I'm going to turn it over to Fiona.
Thanks, Cheryl. Hopefully everybody can hear me okay. My audio, I think, was a little bit muffled earlier, so I'll just do my best to talk loudly. For anybody who joined after our introductions, my name is Fiona Wolfe, she, her pronouns. I work in the health law team in our Rochester office. So not surprising, we're going to be sort of moving on to talk a little bit more about accessing and availability of healthcare services. But before I launch into the second half of the presentation, I just want to pause to check in and see if there's any questions. We obviously have the chat function here on Zoom. We're a relatively small group today, so please don't hesitate to type your questions in there or potentially raise your hand. And we should have time at the end as well for any questions. But just with it being a smaller group, just want to encourage everybody to, don't hesitate to chime in if there's something that you'd like clarification on or have any specific questions. Okay, so just like Cheryl had kind of pointed out earlier with, general language access with any public services or any agencies that individuals are interacting with, we want to be thinking really broadly about healthcare services in New York in the context of language access. So interpretation services that we were discussing earlier and language assistance has to be provided at no cost by quite an extensive list of healthcare services. You get Medicaid, Medicare, Child Health Plus, those are all federally funded programs. And like Cheryl had noted at the start, any dime of federal funds and those federal protections do kick in. We also have anybody accessing their services at hospitals, pharmacies, nursing homes, the health plans, the managed care organizations, universities or other places with health or social service research programs. We've obviously got the state, county and local health agencies, the state Medicaid agencies, the local welfare agencies at the state and county level. Obviously relevant for this presentation, but the programs for HIV, people with HIV/AIDS, families, youth and children. And then there's also public and private contractors, subcontractors and vendors that all sort of fall within this big umbrella. And then at a very day-to-day level, the physicians and other healthcare providers that are clients and that we are all interacting with, right? Anybody who's receiving that federal funding, any Medicaid providers. So the first thing to look at is at that point of applying for assistance. And again, focusing in this half of the presentation on people applying for Medicaid or other health insurance options. You want to be indicating on the application that the applicant is going to need information provided in a language other than English. And there should be an opportunity on the Medicaid applications to just sort of check a box on the front page. And the agency is going to have to provide bilingual workers or interpreters and the translation of the vital documents that we've been talking about. And if the agency is working with any contract, sub-agencies in there, they have to provide the language assistance services to the same level. So what to do if a language access issue arises at the point of applying for assistance? Well, you want to make sure that you're documenting any and all incidents. Contact a supervisor, take it up the chain. Sometimes things can be resolved just by bumping it up one level, but more often than not, you want to be ready to file written complaints with the agency itself or with HHS when a language assistance services are not provided as they are required. And we'll talk through this in more detail. So before turning to Medicaid, I do want to touch on and talk a little bit about the uninsured care programs. Now, these are available through a federal grant, right? So those federal protections that we were talking about all kick in. And it's a federal grant that's administered through the New York State Department of Health. And the uninsured care programs, they're really meant to be transitional coverage for people with HIV who don't yet qualify for Medicaid for one reason or another. And we have several different uninsured care programs in New York. We have the AIDS Drug Assistance Program, commonly referred to as ADAP. We have ADAP Plus, which is the drug program plus primary care. HIV Home Care Program. ADAP Plus Insurance Continuation, or the acronym there is APIC. And then Pre-Exposure Prophylaxis Assistance Program, or PrEP. So
what do each of these programs cover? Well, this slide sort of dives into it in a little bit more detail. ADAP is going to cover free medications for the treatment of HIV and AIDS and other opportunistic infections. And ADAP, as a standalone care program, that can help people who have Medicaid with a step down. And we'll be talking about Medicaid as we move through the rest of the presentation. ADAP Plus, as I said, has the prescription element, and then it also has free primary care services at selected clinics, hospital outpatient departments, office-based physicians, and lab vendors. HIV home care, you're looking there at skilled nursing, home health aid services. Obviously, it kind of says it in the name, home care services related to or that are required for HIV positive individuals. Then we have APIC, which can pay for commercial health insurance premiums for individuals who are enrolled in the ADAP program. And then the PrEP app, which will cover HIV testing, STI and STD testing, and supportive primary care services through eligible providers. Now, there are no fees charged to any participants in any of these programs. The uninsured care programs, they pay all the enrolled pharmacies directly for all medications dispensed, etc. So that was what it covers. What's excluded from the uninsured care programs? Well, pharmacy, drugs that are not included specifically in the ADAP formula. If the drug is not on the ADAP formula, then it's not included. Emergency room services, substance use disorder services, methadone maintenance, any ancillary services like labs or procedures that aren't included specifically in a clinic visit. Rehab therapy, so vocational, physical, speech, etc. Case management and social work, which can really be key. That's not included. Psychiatric and mental health, extended visits, not included in the uninsured care programs, and then inpatient services. So what are the eligibility requirements? The income limit for ADAP is currently 500% of the federal poverty level. So to give that a dollar amount in 2022 for an individual, a household of one, that cap would be $67,950 a year. That would be the income limit. And it goes up based on household size. You do have to have and show proof of New York State residency to enroll in any of the uninsured care programs. But an important note is that US citizenship is not required. There's not an immigration requirement, it's a New York State residency requirement. Medical eligibility is that the individual either has to be HIV positive or at risk of acquiring HIV. And the medical eligibility is determined and consistent with the guidelines for pre-exposure prophylaxis, and I've included a link to those in there. And I should say as well, the financial eligibility, those limits that we were talking about, that's calculated on the gross household income. And there are certain exclusions. So any Medicare and Social Security withholdings and the cost of healthcare, there's certain things can be taken into account.
Excuse me, Fiona.
Yes.
Sorry, this is Alexia. I just wanted to direct folks' attention to a very timely message in the chat. Francisco would like folks to know or be aware that the uninsured care programs offers trainings in both English and Spanish, and Francisco has been kind enough to provide their contact info in the chat. Just wanted to point that out for everyone.
Thank you so much. Thank you, Francisco. Yeah, please, anybody who wants to add content, if there's pertinent things to share, timely announcements, let's get the information flowing. That's fantastic. I mean, I will certainly say, and as we move to this next slide, where we're talking about accessing the uninsured care programs, It's very clear that a lot of time and effort has gone into making sure that there is information made available in other languages. So that's certainly really cool to know that some of the trainings can be made available in languages other than English. So thank you for sharing that with us. So if an individual is looking to apply for one of the uninsured care programs, then I've included the link to the Department of Health website there. There is a single application form that can be used to enroll in ADAP, ADAP Plus, the HIV home care program, and PrEP app. There is an additional application form that's required for APIC, but all of those resources are available at that link. It's a very user-friendly website, and it has a lot of information, including eligibility criteria, covered services. As I mentioned, the application forms are all linked on there, fact sheets, and I've included the helpline number, the 1-800 number for in-state and out-of-state, and the TTY number. Anybody who's applying to the program, like when we were talking about eligibility, as I said, they're going to have to provide proof of their income and proof of New York State residency. They will have to supply a medical application that's signed by a licensed medical professional, and that will be to verify their medical eligibility for enrollment. And then if somebody's applying for the home care program, they have to also include a treatment plan by their physician. And then once determined eligible, they're going to receive an enrollment card. And then that's the card that they're going to use to receive care from any of the ADAP, or sorry, the uninsured care program. I tend to say ADAP, but when I'm referring more globally to the care programs, that's the card that they're going to use when they're accessing services through an enrolled provider. Now, just to remember, as I said, immigration status is not a factor. And individuals who are enrolled in Medicaid are not eligible for the programs. Like we said, it's really for individuals who are maybe awaiting Medicaid eligibility determination or are ineligible for Medicaid because of other factors, which could potentially include immigration or income. Anyone who's enrolled in one of the uninsured care programs, the programs are supposed to be identifying people who are potentially eligible for Medicaid and encourage them to apply for Medicaid, because that's going to be your preferred coverage option if eligible, because it has a broader range of services. Timely point to move on to talk about Medicaid. Any more questions or points to note on the uninsured care programs, Alexia, before I move on?
Nope, nothing on the other uninsured care programs. I have one question I'm going to save until the very end that has come in privately. But other than that, I just want to encourage folks to keep utilizing the chat. Yeah, thanks.
Thank you. Okay, Medicaid, very broadly, joint federal state program, and it's administered at county level by the states and provides health insurance coverage to millions of Americans. And as I think probably everybody knows, the numbers of Medicaid enrollees in New York State increased significantly since the public health emergency. Since the start of the public health emergency, we have many, many more Medicaid enrollees over the last couple of years. Now, Medicaid has two basic categories of coverage. We have MAGI, that acronym is Modified Adjusted Gross Income. So we have people receiving MAGI Medicaid, and sometimes that's referred to as Marketplace or Expansion Medicaid because it's administered by the New York State Health Marketplace. And then there's non-MAGI Medicaid, and that's for people who have Medicare or are over the age of 65 or who have a disability. It includes Medicare savings programs and SSI beneficiaries. And non-MAGI Medicaid is administered by the local departments of social services or HRE in New York City. So accessing Magi Medicaid, so Medicaid through the New York State Health Marketplace. This is the Medicaid coverage that's available to adults aged 19 to 64 who do not have Medicare. Children will also receive Medicaid through the marketplace as well. And there's a separate category of parents and caretaker relatives of children. Little exception there, because in the previous slide, I said if you were over 65 and if you had Medicare, you would have non-Magi Medicaid. Well, if you're a parent or caretaker relative of children, then you can access Magi Medicaid through the marketplace. And with pregnant women, little caveat there, can have Medicare. Applications are made through New York State Health Online or by phone or through an in-person assister. And we've included the link in there and the telephone number. And the New York State Health, these resources are available in many languages because they're required to, right? They have to put this information out. To give an income guideline, because obviously Medicaid is determined by income to some extent. For a household of one, you're looking at an income limit of $1,563. And for a household of two, it goes up to $2,106. And that's for your Magi Medicaid. Now, what to do if you encounter a language access issue with New York State of Health? Well, the marketplace, New York State of Health, is required to provide free language assistance services. And we've talked a lot about, the importance of having qualified, competent interpreters, and they have to provide their written information or vital documents in other languages. If anybody is looking to submit any complaints against New York State of Health, then I've included the link on there with more information about their complaints process. There's the option to email the Diversity Management Office, dmo@health.ny.gov, or you have the option to file a civil rights complaint with the Office for Civil Rights. And I've included a link in there to the portal where complaints can be submitted online, or they can be submitted by mail, and I've included the mailing address, or complaints can be made by telephone to the 1-800 number or to the TTY. Turning to talk about accessing non-Magi Medicaid. So this is for your individuals over 65 with Medicare or with a disability. So this is through the local districts. So every county has its own office, or if you're in New York City, then you're applying through HRA. There's the possibility of in-person assistance through a facilitated enroller. And it's very much a paper application process, right? So in the marketplace, a lot of things can be done online, but for non-Magi applications, paper application process is still where we are. And we've included links on this slide to the relevant forms. The main form, the DOH 4220, is available in English, Spanish, Chinese, Haitian Creole, Italian, Korean, Russian, Yiddish, Polish, Bengali, and Arabic. And as I mentioned before in the slide where we were talking about applying, you would be indicating language of choice in your first page of the form, and the department, the local district, should be noting that language preference, and that's how they should be communicating with the individual going forwards. But as Cheryl was sort of alluding to, it's not always how it goes in practice, right? So again, a lot of information on this slide, a lot of links to kind of click in and have a look at. But what I do want to highlight when we're talking about non-Magi Medicaid are the income limits, the sort of the eligibility. We have lower income limits right now for non-Magi Medicaid, sorry. So for an individual, the income limit is $934. And for a couple, it's $1,367. So those income limits, those are lower than the limits that I was giving for your Medicaid through the marketplace. And there's also a resource limit for non-Magi Medicaid. Currently, that resource limit is 16,800 for a single person or 24,600 for a couple. Again, compare that with Magi Medicaid through the marketplace where there's no resource limit, which is a good time to flag up that we have some changes coming next year. We'll be talking about it in later slides, but there is going to be a higher income and higher resource limits coming in 2023 for non-Magi Medicaid, which is a really good and a really positive thing. And in the health insurance world, I feel like we don't always get to share positive news. All right, you've made your applications, you are Medicaid eligible, you have Medicaid. Most adults are going to have to enroll in some form of Medicaid managed care, right? That's how they're going to actually receive and access their services. So I want to make sure that we highlight just a couple of programs that are relevant to individuals who are HIV positive within the Medicaid managed care world. And the first one is health homes. What are health homes? Well, it's not a physical place, right? It's not a home. It's a group of healthcare and service providers that are going to work together to make sure that their enrollees get the care and services that they need. Individuals who are HIV positive will automatically qualify for health home services. So it's this added care management in addition to accessing the actual services, the regular Medicaid managed care services. So you're looking at care management with health providers, behavioral health and substance use disorder services, connecting to necessary medications, housing issues, extra assistance applying and recertifying for social services, and really other support services that are identified as necessary for the individual. Health home enrollment is not mandatory. I just wanted to sort of flag it up, but individuals will be enrolled through their managed care plan in their county. And we also have, well, some areas have the HIV special needs plans, or HIV SNPs as they're commonly referred. These are very specialized Medicaid managed care plans that are specifically designed to meet the needs of people living with HIV and AIDS. Unfortunately, they are only available in New York City. So there's a geographic restriction on who can actually enroll in HIV SNPs. You can be HIV negative, homeless, or transgender. That's your eligibility classes. And dependent children of individuals can also enroll in HIV SNPs. It's going to cover all Medicaid services, and then there's the add-ons: an HIV specialist primary care physician, HIV care coordination services, more detailed and relevant information about HIV medications and side effects, treatment adherence services, HIV prevention and risk reduction education for HIV negative members. So again, you can choose to enroll directly in an HIV SNP at the point of Medicaid enrollment. Clients with Medicaid through the marketplace, they can enroll in SNP plans there, or clients with Medicaid through HRA would be calling Medicaid Choice to enroll in a SNP. As I said, I wish these were more readily available across New York, but for people who are working in the city, definitely something to be aware of. Now, as I said, most people will be accessing their Medicaid services. They will be enrolled in Medicaid managed care. So let's turn to look at language access more broadly in the context of Medicaid managed care. Because really a lot of sort of frequent interactions that individuals are going to be having is going to be with their health insurance plan. So there's a model contract for Medicaid managed care and for the HIV SNPs and the health and recovery plans, commonly known as HARP. And that model contract, it's a few years old now, dates back to March 2019, but that's the model contract that all of the managed care plans will be based on. Now, language should not be a barrier to receiving any of the covered Medicaid services. All plans should have bilingual staff, have their written materials prepared in multiple languages, They should be advising their enrollees that they're entitled to receive language interpretation services upon request and, of course, at no charge to the enrollee. They have to provide those services free of charge. It's required. And the plans should also be the resource that Medicaid enrollees can go to find the names, locations, and telephone numbers of providers in the plan's network who speak their language, right? The plan is required to provide that information to its enrollees. So turning now to complaints about managed care plans, right? We talked about what they're supposed to do there. What if they're not complying? What if we're hitting a problem? Firstly, all Medicaid managed care plans have to provide care coordination for any of their enrollees with high needs. And that encompasses people with chronic illnesses, HIV, or physical developmental disabilities, or anyone who needs long-term services and supports. So, the plans are supposed to have adequate case management systems to identify the service needs of their enrollees. They're supposed to be based on, usage and data. They're supposed to be identifying people who might need the added care coordination. They should be screening based on their claims data. They should be appropriately training their staff to function as case managers for any special needs populations. If they're not doing it in-house, they should be subcontracting for case management. And they have to inform their enrollees about services that they might be eligible for, including potential referrals to health homes. The plan's member services department, that's frequently the care coordination unit for the managed care plan. So, if somebody is dissatisfied with their plan or any of the plan's employees or the providers or the contractors or the services or the information, that's sort of the place to start, right? And all plans that are certified by Department of Health must have a process to receive and respond to any complaints and grievances that are filed with the plan. Individuals can make complaints, file grievances with their plan verbally or in writing. And there's also the option to designate somebody to make a complaint or grievance on your behalf. The member handbooks for each plan, that should spell out the plan's complaint and grievance process. And like we were talking about earlier, the member handbook is a document that should be being made available to enrollees in their language. So you can see there could be a little bit of a circular problem with the plan, right? They're maybe not making the information available to an enrollee, and there's not sufficient information to the enrollee about how to escalate with the plan or how to get those problems resolved. So you can see why oftentimes the next step is required, okay? Try and resolve something with a plan, but it can be more appropriate to contact one of the state government agencies when there's an issue going on. Now, the agency to contact is going to depend on the type of healthcare plan, and it's going to depend on the type of complaint that's involved. And there is no requirement to file a complaint or grievance with your plan first, okay? You don't have to exhaust that. It is absolutely your right to take the complaint straight to one of the government agencies. And then they're going to review or investigate, and they might work with the health plan to correct the issue or the problem if something has been identified. We've included a link in there, list of government complaint contacts. That's a very comprehensive chart that sets out okay, if somebody is in this type of plan, then this is the agency to which you would file the complaint. And I would encourage you to bookmark it and keep that to hand, because it's certainly something that we refer to quite frequently. So for example, if an individual wants to complain about language access issues within their mainstream Medicaid managed care plan, then the entity to contact is the New York State Department of Health Managed Care Complaint Unit. And there's always a mailing address and an email address included. Again, individuals can file complaints themselves. If they want to have somebody make a complaint on their behalf, because this is sort of direct to a government agency, just be prepared. They're probably going to be asked to sign a written authorization form or release to allow the agency to share their personal healthcare information with their designated representative. And then once all that information is received, as I said, the agency is going to sort of review and investigate and hopefully work with the health plan to correct the problem. And they do have to issue, they have to inform you about how the complaint has been resolved. Okay, we're jumping around slightly, but to talk a little bit more about sort of accessing Medicaid, specifically for immigrants here in New York. Now, New York State, the non-Magi Medicaid, is available to immigrants if they hit those income eligibility requirements that we were talking about, who have certain documents in hand. So if they have a receipt, an I-797, or other proof that the Immigration Services is aware of their presence, and that's a status known as PRU-call. Also available to immigrants who fall into certain designated categories, temporary protected status, asylum, refugees, DACA, the U visa, the T visa, and certain work authorizations. And there is no 5-year wait for individuals who fall into those categories, and also no social security number needed to start the application process. We've got a nice little highlight on the screen there to flag up some changes that are coming next year. And again, these are positive changes. These are expanded Medicaid eligibility, expanded coverage that's coming next year. We have pregnant women who would otherwise be out of status are going to be eligible for Medicaid for the duration of their pregnancy and 12 months post-pregnancy. That's new for 2023. And then also another really big important change is the expansion of Medicaid for people over 65. So next year we have this change coming that New York seniors who would otherwise be out of status are going to be eligible for Medicaid if they're over 65, again, if they hit those other eligibility criteria, including income. We've heard from New York State that there's going to be, we've heard from DOH that there's going to be a sort of an automatic switch. Alexia, correct me if I'm wrong on this, but that they have it about 20,000, between 20 and 30,000 over 65 individuals who are currently receiving emergency Medicaid are going to become automatically eligible for Medicaid once that change takes effect. But we believe the numbers are obviously going to be higher than that, because that's only catching people who already have emergency Medicaid. And as Cheryl was talking about before, there's a lot of chilling effects and people not wanting to apply for Medicaid for a variety of different reasons, including potential fear of public charge. So there's going to be definitely a lot of outreach and a lot of education happening next year to make sure that everybody who falls into that over 65 category is aware of the expanded eligibility and aware that they can apply for and obtain Medicaid.
Yes, Fiona, would it be okay if I just jumped in for a couple things here?
Please do, because this is all
This is the most important slide for our world, I would say, at least. I just want to point out a couple things. I did write out in the chat the coverage for pregnant women. I just want to clarify, it is post-pregnancy. The reason why that's important, the common phrase is postpartum. Postpartum actually means post-delivery. So I wanted to just be clear that this new coverage applies to anyone who was pregnant, regardless of the outcome. So someone who miscarries or delivers it, or there's a stillborn, or they had an abortion. So it still applies to any woman who is pregnant. And then I do also just want to add with regards to emergency Medicaid, I know we're not going in any real detail about emergency Medicaid, and we do have a little note there that it is not comprehensive coverage. I really want to emphasize that again. It sounds like it's Medicaid. It's really just available for certain situations, emergency situations, where life is threatened. That's that life or limb, I would say, is threatened. So it sounds a little misleading, I think, when we say that certain folks are eligible for emergency Medicaid, because it's not comprehensive coverage. It's not enough. And I just want to point that out. And then one last thing, Cheryl was kind enough to put in the chat that if anyone has any questions regarding immigrant eligibility for benefits, to reach out to her, and she left her email. I also put my email and Fiona's email in the chat as well. Believe it or not, we really did not go in depth in Medicaid today. This is sort of like grazing the surface here. So if anyone or any agencies would like any more detailed Medicaid trainings or Medicaid with Medicare trainings, just shoot me and Fiona an email. We'd be happy to arrange that. And I think this is actually a good time to ask the question that came in earlier that I had. I believe this question will be for Cheryl, so I just want to call her attention to this. Someone asked if we have any information available on public charge in Spanish. I guess there's an agency or two or a couple agencies that are interested in a training.
Yes.
Oh, perfect. I thought you might. So feel free to, if you want to answer that, go ahead.
Sure. As I mentioned earlier, there was a wonderful coalition called Protecting Immigrant Families, which has worked nationally throughout the last few years to oppose the changes in public charge rules, and also to educate community members and advocates, regarding the realities of public charge and what is or is not safe to use in terms of benefits. I have a whole separate training on public charge, so I'm happy to do that for anybody who would like it. I have it in English and Spanish, so feel free to ask me. I've been doing a lot of community presentations, but you can also get a lot of brochures as well as videos on that Protecting Immigrant Families website, which I shared earlier, and I'll drop it in the chat again. And I also, as long as I have the mic for a sec, I also put something in the chat related to Medicaid coverage, and that even though it was a great victory to get Medicaid coverage for undocumented seniors effective in 2023, immigrant advocates are continuing to work for the expansion of that to all people who are undocumented, who are income eligible, so that everyone will have access to Medicaid. So if you're interested in joining that campaign, I did put a link in the chat for the Coverage for All campaign. Thank you.
Thanks, Cheryl. And yeah, it sounds like folks are really interested in changes for 2023 training. That is a great segue into the next slide, which I'm happy to take over for Fiona for just a couple slides, just because I have done a public health emergency training quite a few times. In the public health emergency and unwinding of the public health emergency trainings I've done, we have included, there's actually a lot more changes coming in 2023 related to public health insurance, not just the couple that we flagged there. We have all that sort of prepared. I'm happy to arrange a training in January for folks who might be interested in that. Definitely let us know. I'd be excited to do that. That would be so fun. So we are definitely eager to arrange that. And so yeah, let's talk a little bit about what the public health emergency means. So basically, right now we're in the federal public health emergency. It is regularly declared by the Department of Health and Human Services by statute 90-day increments at a time. Right now, the most recent one was extended from October to mid-January. The Department of Health and Human Services has promised to give states a heads up at least 60 days in advance should they not renew the public health emergency. It has been in effect since March of 2020. We did not get that notice back in November. So right now it will continue past mid-January. We do know that for a fact, but we don't know that it's going to be extended for another 90 days. They actually did let folks know that they weren't promising that it was going to be renewed another 90 days. They can't guarantee that. So we're kind of in limbo right now, where we don't really know when this public health emergency is going to end. Let's talk about why that matters. So basically, during the federal public health emergency, no one with Medicaid coverage on or after March 18th, 2020 can lose that coverage during the PHE unless they move out of state or voluntarily close their case. This includes individuals who have aid continuing and have lost their fair hearing. So if they've been denied Medicaid, or Medicaid was reduced, Medicaid was reduced during the public health emergency, but they had aid to continue and they lost their fair hearing, they still get their aid to continue throughout the duration of the public health emergency. It cannot be reduced or cut. This means that there's no recertifications taking place. So people may still be getting their recertification notices in the mail, but there's no consequences to those who don't return it. Throughout the PHE, Medicaid, Essential Plan, and Child Health Plus coverage has been extended. So it's not just Medicaid, it's also Essential Plan and Child Health Plus. Typically, these cases are renewed for 12 months at a time. We are aware of some Medicaid cases that are being renewed only for 6-month increments at a time. These would be cases where the individual has a spend down. They're contributing excess income to meet the Medicaid threshold. Also, the Medicaid buy-in for working people with disabilities. They're getting extended for 6 months at a time. Could not tell you why. I don't know why. That's just in the gist, which I'm happy to share with folks if that is of interest. I also want to note, I don't know the difference, so this isn't that helpful, but I know that there is a difference between Medicaid only cases and Medicaid SNAP TA cases. I just want to point that out. There's some different rules happening there. Again, if anyone has questions or would like more specific training on this topic, we're happy to do that, but I'm just going to move to the next slide here. Thank you. So just some tips as the public health emergency possibly unwinds, as we reach the end possibly of the public health emergency. Again, it's not over yet. It is right now currently lasting through mid-January. It's definitely getting renewed. We don't know how long it will be renewed for. Advise your clients to verify their address and phone numbers with the marketplace, with the county, with HRA, so that they make sure that they get these important notices that might be coming. Advise clients to remain alert for any announcements related to the end of the federal PHE. Advise clients to contact the marketplace or their county if they don't receive a recert notice during the time of year that they normally recertify, that they've recertified in the past. For those in New York City with coverage through HRA, if you don't already, please advise clients to set up an account on Access HRA. And we can also advise clients to start gathering documents that they may need for their recertification, proof of income, resources, proof of payment of health insurance premiums, and trust documents. And then just some more practical points that don't have to do with, documentation and notices, but advise your clients who might lose public health insurance coverage to seek assistance looking ahead to potential coverage options, book any appointments and get prescription refills while they're still covered, and stock up on those free or reimbursable at-home COVID-19 tests, no matter what your coverage, Medicaid, Essential Plan, Child Health Plus, commercial health insurance plans, Medicare, although Medicare Advantage plans will have slightly different rules. Everyone is entitled to 8 free or reimbursable COVID tests per month, and that's 8 per member. So a family of 4, all on the same plan, would be eligible for 32 tests per month. I know that sounds like a lot, but make sure you stock up on those tests as we enter the coldest months and the flu season and the holiday time. If you've got questions on how to access these tests, we didn't put that in here, but I've got that information for you too. So just let me know if you need any of that information. Next slide, please.
Thanks, Alexia.
Yeah,
I can jump back in here.
perfect. Thanks.
Yeah, so to talking about things that are happening at the start, early next year, there's a lot, right? One of those big takeaway tips is make sure everybody is paying attention to any and all notices that they might be receiving from their local district or from Medicaid. We were made aware just last week of 2 new notices that are going to be issued before the end of the year by the local district offices to population groups who may be eligible for expanded coverage based on those changing income eligibility items that we were talking about earlier. So we've included links in there to the GIS. That's the sort of information that's issued by DOH, and then the accompanying notices. The first one is to let people know about changes to the Medicare Savings Program income levels. The sort of big takeaway there is that some individuals who've been eligible for Medicare Savings Program, which is a Medicaid funded program that helps cover Medicare premium costs. That's very, very basic level of it. Because of these changes in income eligibility, they might actually now be eligible to enroll in Medicaid proper, right? Which is going to cover many health services that aren't within Medicare. So that's a big one. And then those income level changes and the resource changes that we were talking about for individuals who are accessing their non-Magi Medicaid through the local districts. They're going to be receiving notices to let them know that they may be, well, let me try and backtrack. These notices are going to go out to people who are currently enrolled in the spend down program. So that means people who have their Medicaid through the local district, they are over that income threshold and they're involved in the excess income or spend down program, right, in order to keep their Medicaid active. Well, they might not need to do that any longer, right? They might be under that, $1,500 income amount, and so they might not need to use the spend down program anymore. Once they are rebudgeted at some point after the public health emergency, once they fall into the timeline for their annual recertification, they will be caught, they will be rebudgeted, but there could be a big benefit to somebody applying in January to be rebudgeted because it's going to affect their potential spend down. So if you work with people in the Medicaid program, have a look at these notices. Like I said, these were just published. So keep an eye, have a look and see what folk are going to be receiving, what they're going to have to understand and potentially respond to. Okay, moving on. A lot of information just covered there. But like Alexia said, we would be delighted to circle back and answer one-on-one questions and whatnot about the changes coming in 2022 because it's just so complex. But let's turn back. Let's look at language access in hospitals because this is a big a big hot topic when we're talking about language access issues. Some key points. Hospitals can't discriminate based on language, race, or immigration status, and they do not share information with immigration agents. Let's just put that out there at the outset. All New York State hospitals are required to develop a language access plan, appoint a language access coordinator. They must provide interpreters within 10 minutes in the ER and 20 minutes elsewhere in the hospital. They have to notify patients about their rights to language services. And patient medical records must include the individual's language preference. Now, Cheryl's already, in her earlier slides talked about, the importance of competent interpreters. I mean, that's a big thing. There's a big difference between providing interpreters within these timelines and providing competent interpreters that are delivering the service that patients need. Family members, friends, non-hospital personnel cannot act as interpreters for patients unless the patient agrees and they have, first of all, been offered the free interpreter services to which they're entitled, and the patient has refused those services. And then, minor children should not be used as interpreters, and Cheryl already discussed that earlier on. So just keep in mind, the language accessibility is legally required and it's not an optional service. The hospitals are not doing their patients a favor or going over and above by doing this. No, this is legally required and they have to have this available. They must provide accurate interpretation of spoken language and translations of vital documents. I know we've already talked about vital documents, but that's going to include patient's bill of rights, financial assistance applications, discharge instructions. And then complaints can be made to the hospital's language access coordinator and to the Joint Commission if not provided. And we put the information in there about if somebody wants to file a civil rights complaint with the US Department of Health and Human Services Office for Civil Rights. I think that might have been included in an earlier slide as well in a different context, but there's the OCR complaint portal. And just flagging up that complaints should be made to OCR within 180 days of when you knew the act or omission that you're complaining about occurred. But there is an opportunity for OCR to extend that period for good cause. This next slide, I think I mentioned at the start, we're based up in Rochester, New York. So one of our big hospitals nearby is Strong Memorial Hospital under the umbrella of the University of Rochester Medicine. So we've included in there just an example so that people can have a look at a language policy, and this one is specifically for U of R. And next slide, again, just to sort of show what sort of poster a hospital would potentially be putting up to show the availability of interpreters for their patients.
Excuse me, Fiona, before you go to the next section, we are running short on time.
Yeah.
I'd like to get to the resources page. I'm sorry if that means we're going to skip these fair hearing slides. I just think that
I think that's, I was actually just about to say, I think we should skip over. It obviously is almost a training unto itself to talk about fair hearing rights. But just to sort of, flag up, if you're appealing against a decision that's been issued by a state agency discontinue changing benefits, you've obviously got the right to request a fair hearing, and language access rights apply throughout the fair hearing process. I think we could probably keep it as broad as that. There's a lot more detailed information in here in the slides. You'll see as I'm just glossing through, including specific information about Medicaid appeals. This is very much the work that Alexia and I do within our health teams. If anybody has any specific questions about appealing against Medicaid denials or discontinuances or reductions, please do reach out to us. That's the sort of work that we do quite frequently. There's information here about how to request a fair hearing through OTDA, and we included this slide just to show the availability of their forms in different languages. And then again, a very sort of hot topic right now is the fair hearing demonstration project. There's a lot of work being done and advocacy that we're involved in with the Office of Administrative Hearings about making fair hearings more accessible in terms of a variety of things, but language access issues while fair hearings are taking place by telephone is a really big issue. So please do have a look at these slides, and if this is something that you have questions about or would like to give input, reach out to us directly, because this is, as I said in the slide, this is a non-exhaustive list of the language access issues in fair hearings right now. It's big. And now I can potentially stop sharing, I think, so that we can go to the resource slides.
thanks, Fiona. And I just want to let folks know that I've saved the chat. So if we didn't get to a question, or if I promise to follow up about a training, we will do that in a post-training email. So not to worry.
Were we sharing some of those resources now?
You want me to share the resource page, the additional
Please.
Resources?
Yeah.
Okay.
While she's getting that going, I just want to say thanks so much to everyone for attending. I know it was a little bit of a longer presentation, so we really appreciate everyone joining today. And don't hesitate to reach out to us with any questions that may arise. We're also available for technical assistance. So yeah, definitely reach out.
Absolutely. Thank you, everybody, for staying with us, especially on those last few slides when I was going at the absolute breakneck pace. But it was good to have questions, you know, with a smaller group like this. I think, you know, we would rather focus on things that that are of interest and of note to you and your clients right now as well.
Okay, and I think what Michelle was trying to pull up, but maybe we won't have time for it, is there, if you go to our website, Empire Justice Center, right here, there we go. We have a wonderful chart, which is regarding immigrant eligibility for public benefits in New York State. So it goes through a variety of different benefits, which may be available, as well as the different categories of immigrants who may or may not be able to access them. We know that there is a lot of misinformation out there regarding this. So, you know, please take a look at it and use it as a resource, and, you know, share it with others who may benefit from this. We also have a public benefits crosswalk, a health coverage crosswalk regarding eligibility for medical assistance based on immigration status. So please take a look at that. Feel free to use that as a resource, and we hope that you find it helpful. And it also goes into, as we stated, some of those protocol categories of folks who may qualify for New York State Medicaid, even if they're not eligible for federal Medicaid. Oh, somebody asked about translation services for trans clients. No, I was mentioning a program called Found in Translation that's in Massachusetts. It's not specifically for trans clients. Yeah, but maybe there is another resource out there that we're not aware of. Thank you.
Thanks, Cheryl.
Okay.
And thank you to Fiona and Alexia for their great presentation as well. And just a reminder for those of you still on, you know, there'll be a training evaluation that'll pop up on your screen afterwards. So if you could take a couple of minutes and give us your feedback, that would be great.
Thanks, everybody.
Thanks,
All right.
everyone.
Thank you. Have a great day, people.
Happy holidays.
Happy holidays. Bye.